So good morning. I wanted to talk about intraoperative neuromonitoring today. We'll go over kind of a variety of topics, what it is, applications, some of the literature behind that, supporting its use, as well as some arguments against it, and then discuss some methods to kind of handle intraoperative changes should they occur. So first, some goals and basic definitions. Intraoperative neuromonitoring is really the only way to interrogate the nervous system integrity while under anesthesia. It allows kind of an evaluation of the baseline structure and function of it. The goal is to decrease the prevalence of iatrogenic neurologic sequelae, so improving surgical precision, detecting impending injury, providing a warning to the surgeon that injury may occur, and then prevent or reduce the incidence of and severity of adverse patient outcomes. Also, there's some component of protecting the surgeon or hospital in the event of spurious litigation, spurious being the key word there. It's not going to prevent all litigation, but it can provide some evidence sometimes. As far as definition, amplitude is essentially the strength of the signal. It's typically measured in microvolts, and it's measured from a baseline peak to peak, or baseline to peak or peak to trough. Latency is essentially the speed of the signal, typically measured in milliseconds per whatever time interval, and then it's the time it takes a stimulus to occur to the occurrence of the potential. We'll go over some of what that means for the different modalities shortly. Baseline is essentially the patient's preoperative level, so this can be prior to positioning or after positioning. This allows a level to compare to intraoperatively to assess any changes. There's also a lot of factors that can affect this outside of neurologic injury, which we'll cover. And then significant change can vary depending on what modality you're using and who you ask, as well as what kind of threshold you're using. But it's typically a change seen with neurophysiologic recordings that's shown to correlate well with intraoperative injury. So it varies from modality to modality. Some of the ones we'll talk about, SSEPs or somatosensory evoked potentials, typically significant change there, just for reference as we go forward, is amplitude of 50%, latency of greater than 10% change. So a decrease of 50% or an elongation of 10% time. And then motor evoked potentials, a little controversial, but increasing a threshold of 50 to 100 volts. And we'll go over triggered EMGs as well, just kind of context moving forward. So relevant anatomy, we're talking about monitoring the spinal cord. So it's really important to know the spinal cord anatomy and the different tracts that are involved. We'll be talking about the lateral corticospinal tract, controlling voluntary motor, and then upper extremity being more medial than that, and lower extremity being more on the periphery. We'll also talk about the dorsal columns, controlling deep touch, proprioception, and vibration, as well as some of the others, which we'll get to. So the whole kind of structure of neuromonitoring is using different modalities, measuring different things via different logistics, but it's a multimodal approach. So it's redundancy built into the system. So your options are essentially active monitoring, which is intermittent stimulation or recording. And that's things like somatosensory evoked potentials, motor evoked potentials, and triggered EMG. And then there's more passive modalities that provide a continuous recording that you don't necessarily have to do any active input for. And that's things like electromyography and electroencephalography, so EMG and EEG. And then each monitoring type, like I mentioned, corresponds to a different structure that can be monitored. And we'll go over those one by one as well. On the right, there's some example of what the intraoperative neuromonitoring tech would see throughout the case. It varies again by modality, and it has kind of the ongoing one as well as the baseline level that you can compare to. And it varies depending on what's going on, anesthesia medications, intraoperative insults, etc. So evoked potentials as a whole is essentially delivering a stimulus in one area and then recording an electrical snapshot in another at a distant part, and by corresponding the two to an expected pathway, you can kind of test the integrity of that pathway. So we'll go over the MEPs, the SSEPs, kind of working in opposite directions there, like you see on the diagram. Starting with SSEPs, it's essentially a surrogate for the dorsal column pathways fed by the posterior spinal artery. It allows you to stimulate a peripheral nerve. That signal then travels up the dorsal column, crosses into the contralateral side, and synapses in the thalamus before ending in the primary sensory cortex. On the right, you can see the diagram stimulates kind of bottom to top in that case, but stimulating the peripheral nerve, traveling up and ending in the sensory cortex. The advantage is it allows you to establish an alarm. You can use it with paralytics because it's not requiring motor function. Unfortunately, there are some significant disadvantages though. It's an average of multiple potentials, usually about 3 to 500. So it can take minutes to elevate and is not as accurate as some of the other modalities with respect to chronologic time. There's also a high documented false positive and negative rate depending on which study and which application you look at. And it doesn't necessarily provide a direct measure of the motor function. It's also very sensitive to anesthetics at time, in particular the anesthetic gases compared to IV anesthetics. So looking at transcranial versus SSEPs during cervical surgery, this kind of talks about the concept of coherent averaging. Coherent averaging allows you to recover a response when the response is buried in noise. So on the picture on the right, you can see the sample. The baseline is kind of noise. And as you have a stimulus, to some degree that's drowned out by the noise around it, which can vary with a variety of factors, things like the bovie, other intraoperative equipment, physiologic, non-physiologic factors. And it allows, although you can see the response, it typically takes multiple averaging of the change in order to become visible. So the calculated average may take several minutes in response to the acute insult. This can lag behind MEPs anywhere from 5 to 16 minutes, with one prominent study showing up to 33-minute delay between the two. In this study, no patients had SSEP changes in absence of MEP changes. So the MEP was sensitive and specific 100%, which is not always the case, but in this study it was, whereas the SSEPs was 25% sensitive and 100% specific. A lot of this is pretty tough because it depends on which study you look at, and that's a common theme throughout this presentation. Those numbers vary a little bit, so we'll try to focus on more trends than anything, but it can be very variable just because of all the different factors that can influence the accuracy. So this is kind of the logistics of how this happens. So the stimulus location in the upper extremity, the preferred is typically the ulnar nerve. The ulnar nerve exits lower than the median nerve, so that allows for full assessment throughout the course. In the lower extremity, most commonly, I think, is a posterior tibial nerve, though you can use the common peroneal nerve as well. And then that stimulus is recorded generally more proximally, so typically in the head, the scalp, although you can record it in other locations as well along that pathway. This follows the 50 and 10 rule, so loss of amplitude greater than 50% or an increased latency of greater than 10% typically indicate a significant change. The amplitude is considered more important as compared to the latency, and a spinal cord injury without an amplitude change is unlikely. So that can help provide some kind of workup techniques as you experience deficiencies intraoperatively that aren't necessarily related to neurologic injury. It may not detect ischemic injury from an anterior spinal artery ischemic event. And you can see in the picture on the bottom left, it just has to do with the blood supply to the spinal cord. So the dorsal columns are fed by the posterior spinal artery, whereas the anterior spinal artery feeds the anterior columns. That gets back to the redundancy kind of overall feature of this of some of these. This is a study looking at post-op neurodeficits, kind of showing the efficacy of SSEPs. Unfortunately, six patients had a post-op neurodeficit despite unchanged SSEPs during intraoperative monitoring. Again, getting back to the need for multiple modalities throughout the case. Transcranial motor evoked potentials, MEPs for short, so I don't have to say that word the whole time. Basically, it's stimulating the motor cortex proximally in the brain, sending the signal down to activate the muscle. So it travels along the corticospinal tract to the anterior horn of the anterior horn cells in the spinal cord, and then travels along the peripheral nerve to the neuromuscular junction where the muscle is depolarized and you see the response. This covers the anterior corticospinal spinal motor tracts, and then depending on where along that pathway you're evaluating the signal depends on how it presents. So in the epidural space, you get either D or I waves, and then at the muscle, which is typically the most preferred method, you get compound muscle action potentials. The advantage is you get a comprehensive motor tract coverage. It's the highest sensitivity and specificity of modalities in most studies However, it does require invasive intermittent stimulation, so that's the twitching intraoperatively. There is subjective alarm criteria we'll talk about, and you're unable to use it with paralytics as a result of no longer being able to test the muscles. There's also pretty significant narrow anesthetic demands. So like I said, typically stimulus location is in the scalp, or approximately in the brain, and then it's recorded along the upper and lower extremities based on the motor group that you're trying to record. This also allows for spinal cord monitoring, like I mentioned. It's more sensitive for motor injury than SSEPs, but the biggest downside in this case is there's no single universal warning criteria. And we'll talk at the end kind of where you cut this criteria based on these three different techniques can really change how many intraoperative alerts you're receiving. The three main techniques, first is the threshold technique. It's essentially a myogenic response below 65% of baseline value, and then increasing 100 volts above baseline doesn't provide recovery of that response amplitude. The amplitude technique is an increase in stimulus to the maximum level as long as the amplitude of response is maintained, and if you're no longer able to maintain that response, then that's considered a positive alert. And then the all or nothing technique is kind of a combination of the two. It's an increase in maximum stimulus as well as a significant decrease in the amplitude as long as a reproducible response is recorded. So you have to have kind of a reproducible there being the keyword. So these two studies kind of help get or show the utility of MEP. So the first one is the diagnostic accuracy in the anterior tibialis related root dysfunction, supporting its inclusion intraoperatively. And then the bottom one, the MEP amplitude change, sensitive and specific to detect new postoperative dorsiflexion injury. And they found monitoring two myotomes is superior to a single myotome. Again, getting back to the multimodal and redundancy, both in techniques as well as myotomes. So this is an example of what the screen would show intraoperatively. It has the left lower extremity on the left and the right lower extremity on the right, both extremities. You can see the muscle groups there. So brachioradialis, neurosii, thigh adductors, tibia, and adductor hallucis. This is kind of the initial view, and then what you'll see is on the bottom left there, the red being the baseline and then the green being the current status, a significant change from that level. And this patient unfortunately did wake up with postoperative deficits in both motor groups. EMG is another method that can be utilized. It's essentially allows for a cross-reference of different modalities. The biggest advantage is its instantaneous feedback. It's passive, continuous, minimally invasive. Unfortunately, there's no guidelines with subjective alarm criteria similar to MEPs, and you're unable to use it with paralytics, so it's slightly less comprehensive overall. Spontaneous versus triggered EMG kind of has two different approaches using the same technology, spontaneous being continuous throughout the case. This is this relies on the fact that normal muscle is electronically quiet or electrically quiet from a neurologic perspective. And then spontaneous firing can detect nerve injury or irritation, typically shorter bursts being irritation, and then larger, more sustained firing being injury. So this can show, if you're doing an ACDF and retracting a little too much or irritating the nerve out as it exits the foramen, this can hit and cause an alert where they'll mention it intraoperatively and hopefully prevent injury, though that hasn't really been shown. Triggered EMG is essentially a time-locked EMG. So instead of being spontaneous, you're actively pursuing the insult. So you're seeking out the unseen, the at-risk neural elements. This is things like the probe during a lateral approach or testing pedicle screws. And then you can also verify the viability of nerve being stimulated. So if you're not sure, you can use a probe intraoperatively and kind of get some more direct feedback that way. With respect to pedicle screw stimulation, this was kind of the founding study of that. This was from Dr. Rayner Lenke out of WashU in 2007. They looked at 4,800 pedicle screws in the lumbosacral spine. Essentially, 8% demonstrated a threshold of less than 8 milliamps, with that being the highest sensitivity and specificity combination. And that correlated with a 0.31 chance of medial breach. Again, not neurologic injury, just medial breach, strictly speaking anatomy here. The theory is that the current flows through the path of least resistance, with cortical bone having a high resistance, and then flowing through a cortical breach to the root depolarizes it at a lower current, allowing it to be picked up. This is essentially saying, does this actually identify incorrect screw placement in this study? They had positive alerts and then removed the screws and tested for medial breaches. And the study also found less than 8 milliamps as the most clinically useful based on the anatomy. And then so clinically useful from a neurologic predictive sense, this is looking at triggered EMG to predict the post-op deficits. They found that the low triggered EMG alarm thresholds are highly specific but weakly sensitive for new post-op alerts, or new post-op deficits. And then patients with new post-op deficits were 10 times more likely to have a pedicle screw stimulated at a low threshold. So not as predictive as we thought or as we hoped, but can be somewhat helpful clinically. From a transhost approach, I think this really could be its own lecture in and of itself, like we've had before, but just to touch on it briefly, EMG has the lowest specificity. It may not necessarily detect nerve compression. It cannot necessarily reliably monitor sensory-specific nerves, and the directional EMG may be helpful given the proximity of the plexus within the psoas, can help navigate kind of where you are. At the end of the day, it's with respect to the other anatomic corridors, so it can help give some sense there. MEPs may accurately monitor the peripheral nerves of the plexus, especially for the quadriceps muscle, but they can be limited by the anesthetic and paralytic options needed to safely complete the case. The SSCP typically in the high lumbosacral plexus is the saphenous, and then in the lower lumbosacral plexus is posterior tibial or peroneal nerve. There's no major consensus on what to do, whether you're using one versus another or a combination of them. So this was kind of getting into the utility of neuromonitoring. A lot of these studies I think are maybe a little controversial, but I was just kind of shocked when looking at the literature, going through them, especially for ACDFs. So this is 540 patients looking at cervical spondylitic myelopathy using both MEPs and SSCPs. Overall incidence of alert was 1.3%. They were all motor alerts and they were all false positives, so no clinic deterioration postoperatively. So false positive rate was 1.4% for anterior-based approaches and 1.3% for posterior-based approaches, and they had no false negative alerts. So ultimate conclusion there, 0% sensitivity and 98.7% specificity, though obviously specificity is the important takeaway. They didn't really get into it too much, but there was added setup time as well as operative costs of the surgical procedure. This study looked at that a little more closely, although it was a retrospective database study. They looked at 141,000 ACDFs from 2009 to 13. Essentially, 9,500 of them used intraoperative monitoring, so about 6.8%. I thought it was used a lot more than that, and some of the other studies support that as well. So I'm not sure how much to weight this, but there's no significant association between neurologic injury and intraoperative monitoring, although the deficits postoperatively were associated with age greater than 65, a multi-level fusion, elevated comorbidity index, and non-elective admission, so meaning trauma etiologies most likely.
I think they're from Canada, Mike, which might be why the low rate.
Okay.
They're going to regulate their dollars a lot differently than we do here.
Yeah, thank you. That makes a lot more sense. I didn't recognize that when going through it. Does make a lot more sense. But they found essentially a $6,800 hospital charge for cases that did use the intraoperative monitoring, and that was significant there. You can see the overall hospital charges below, 59 versus 66,000 for ACDFs. Pretty low rate of neurologic complication as well, no different between the two groups, like I said. So this looked at routine use for ACDFs for both myelopathy and radiculopathy. Essentially, they wanted to assess the incidence of neurologic injuries with and without, like the others. Retrospective review of a database with cases from 2007 to 2014, so relatively recent. Again, both myelopathy, radiculopathy. 2,600 cases were monitored out of essentially 1,500 total, so about 17%. And then there was a decrease over time. So in 2007, 22% of the cases were monitored versus just 4.3% in 2014. And then SSCPs only for 48%, MAPs only for 5%, and then combined for 46% of the cases that did use the monitoring. There's no difference between neurologic injury with and without 0.23 versus 0.27%, and younger age was associated with higher utility of intraoperative monitoring. I'm not sure if there's a specific reason for that other than just kind of describing a finding that they saw. I think, a lot of us would do that naturally in practice. Significant regional variability as well, looking at the West, 22% essentially versus the Midwest, 13% in terms of use of monitoring. And then looking at the impact and potential risk factors, this is a retrospective review of 176 patients with spinal deformity using both the MAPs and SSCPs. Their cutoff was a decrease in greater than 75% for MAP, and then amplitude using the 50 and 10 rule. They found that there was a better sensitivity and specificity when utilized together, again, getting back to the redundancy and multimodal approach. And then they found risk factors for neurologic deficits in general being near osteotomy, kyphosis, and a Cobb angle greater than 90 degrees. I don't think any of those are particularly unexpected. This is a study from Spine in 2022, prospective multi-center database study looking at 311 patients. Essentially, they wanted to identify when the alarms occurred, and then also looking at whether or not the intervention to respond to that was successful or not. So primarily adult spinal deformity patients, the alarms were most significant during the deformity correction or the 3-column osteotomies. You can see in that chart below the bottommost row, so the surgical maneuver unrelated, was 22 alarms. So it was by far the majority, but those were considered responses to either physiologic or non-physiologic things outside of the actual deformity. So adjusting blood pressure, kind of responding to those insults, had a 100% rescue rate as expected. So once you remove those, then by far the two most significant were deformity correction and 3-column osteotomy, which are still relatively high rate overall, but as we all know, high risk procedures as well. And then these are kind of more of their in-depth, patient-specific deficits on the left. So these are patients that actually had motor weakness postoperatively. The first 11 are true positives, and then the bottom 3 are false negatives. So the true positives, I think, kind of speak for themselves a little bit, but the interesting thing here is the false negative rate. To me, you can see that there were 3 that weren't picked up intraoperatively at all, but did have a deficit post-op. And looking at their kind of amplitude percentage, so the row 13 and 14, 65 and 54%, I think kind of lowering to that threshold would have a lot of false positives. So that may, not that it's intolerable, but that may greatly complicate things and provide a little bit of complication intraoperatively in terms of the logistics. And then looking at independent factors for nerve root injury, they found pre-existing motor weakness as well as 3-column osteotomy being significant risk factors. So getting into kind of why some of this can go wrong, a lot of these, like we saw in that previous study, can be related to anesthetic effects or other intraoperative factors that aren't necessarily related to direct injury. The gases can disrupt MEPs and SSCPs amplitude and latency, with nitrous being the most significant, but all will affect it to some degree. By far, the most preferred anesthetic is TIVA, or total intravenous anesthesia. Propofol has less of an effect on these factors, and then ketamine can actually increase the signals as well. Opioids pretty negligibly interact with this stuff. However, intraoperatively paralytics are obviously going to significantly affect MEPs and EMGs, but SSCPs can still be utilized, though no longer in a multimodal nature. So with respect to kind of where we've talked about the significant change for SSCPs, the 50-10 rule, MAPs, you have your 3 different options, but I think most people use a 65% drop in amplitude from baseline. And then EMGs, no significant guideline, but a prolonged high amplitude discharge will indicate an injury. With that in mind, kind of all this stuff is going to be affected by a variety of things. So baseline variability of a patient, both preoperatively as well as after positioning, or after induction of the anesthesia. Known artifacts are things like Bovie, other machines in the room, manipulation of the nerves. The anesthesia, like we discussed, the length of the anesthesia. So there's a concept of anesthetic fade, meaning throughout the duration of the case, the anesthesia kind of wears more significantly or can affect the readings more significantly over time as it builds up into your system. Pre-existing neurologic injury can also affect it. Most significant myelopathy or strength greater than 3 out of 5. And also your index of suspicion. So is it immediately following reduction? Is it the fellow holding the Bovie, or are you kind of in charge? So if it is the fellow, that's probably what we're looking like standing there on the right. But your differential is going to be pretty much the same regardless of what's going on. So there's either a technical or a non-physiologic thing, meaning either a wire pulled out, a cable disconnected, there's some problem with the actual equipment being used to monitor. It could be related to background noise, so bed position, the drill, Bovie, microscope, serum, lots of equipment in the room that can be affecting that. I don't really talk about it here, but a bear hugger can significantly play into this as well. About a 1 degree change in body temperature can greatly affect the readings that are obtained. That would be one of the physiologic factors, still unrelated to surgery. So temperature, like I said, also changes in blood pressure, hemoglobin, different anesthetics being altered throughout the case, especially with changes in the anesthesiologist during breaks and patient positioning on the actual table. And then, of course, physiologic surgical changes. So those are typically a focal deficit or focal alert, and often with rapid onset. So when you do get an alert, kind of how do you handle it? The first thing is alert identification. So you have to identify the change and verbalize the criteria. A lot of this stuff comes back to communication between both the surgeon, the anesthesiologist, and the neuromonitoring technician. Then once you have an alert verbalized, kind of changes the dynamics a little bit. First, you need to figure out why that alert happened before attempting to correct it, although many of these things are occurring simultaneously, with a lot of the times the treatment kind of confirming the correction or confirming the underlying etiology. So once you verbalize, essentially it's physiologic or non-physiologic. So it's either surgical, which is thankfully uncommon but more focal, or non-surgical, so more common but more general as well. So a lot of the factors that we talked about, the anesthesiologist is going to communicate, the surgeon is going to communicate. The anesthesiologist initially is going to decrease or stop the anesthetic gases to optimize the signal. They can use ketamine to maintain amnesia, and then they'll work on the physiologic factors primarily. So fluid bolus, pressures to increase blood pressure. Most people recommend a MAP of 80, though I have seen some recommendations for 70 as well. And then ensuring that the brain and spine are adequately perfused to avoid ischemic changes. You can provide blood products for significant blood loss if that's a suspected etiology. You can also check that relatively easily intraoperatively. The surgeon's going to pay attention to what they just did, with the kind of caveat that some of these studies show change 33 minutes after the initial insult. So if you just did the deformity correction, you're going to release it, you're going to adjust the traction. If it's an ACDF with shoulders taped, you may release the tape. You can apply steroids IV into the field, though that may be a little less common or a little controversial, excuse me. Ultimately, you can perform a wake-up test or abbreviate the surgery. At the end of the day, this could also be none of the above. False positives do occur. You kind of essentially need to just evaluate critically and proceed based on your index of suspicion. I think kind of at the bottom there, the two critical things aside from communication, which I started off with, is one, don't do nothing. So if you do get an alert, don't just assume it's equipment, kind of prove it. You know, you have to investigate it first. I think most people will say that the alert is okay, but not kind of responding to it appropriately is not. And then finally, document. So if you have an alert, you need to remember postoperatively to document what you did to assess it and how you responded with it. This is kind of one of the landmark studies from Dr. Lenke, looking at neuromonitoring in deformity patients, and specifically what to do and recommendations / guidelines for responding to intraoperative alerts. This is a lot to go over. A lot of this is happening simultaneously. You can see the chart on the right. I think it's a really good checklist. I think some ORs even have it printed out in the room, but I think it can be very useful, especially starting out in practice. Typically, these don't happen at the beginning of the case. You're probably mentally fatigued and physically fatigued, and having a checklist, I think, is a really good idea. Some summary of that chart kind of over on the left here. Essentially, you want to localize it. So at what level is the alert coming from? If you can localize it, sometimes peripheral upper extremity monitoring can be helpful to help localize the level of injury. If you did just do something, you need to reverse it. So if you just did a deformity correction, if you just altered anything, essentially try to undo it. You can bring in intraoperative imaging in order to check the implants. So things like intraoperative C-arm, O-arm, etc. The anesthesiologist simultaneously will be increasing the map in order to provide adequate perfusion, checking a hematocrit to optimize blood flow, checking position, temperature, blood pH. The neuromonitoring will also be going through technical issues with their equipment to make sure that that's not assessing it, impacting it. You can, if the thoracic spine is instrumented, they recommend sequentially removing thoracic screws, starting with the screw at the lowest threshold. So basically taking the screw out, palpating the pedicle tract, making sure it's adequate before replacing it, and if there's any concern, just removing it. And then they also note an kind of intimate association between thoracic nerve roots and the anterior spinal artery. So if you are taking down or sacrificing a thoracic nerve root in order to safely complete the operation, they recommend not ligating it completely initially and just clamping the nerve root with, they use an aneurysm clip for 5 minutes to observe changes. So that allows it to be undone if any changes do occur. I think that is a very good idea. My question, I guess, to them would be 5 minutes based on some of the other literature that we've seen may not be enough time, though it's certainly better than nothing. And with a ligation of the anterior spinal artery, that would definitely be a significant change that probably would show up sooner than any smaller change in isolation. At the end of the day, the wake-up test is the gold standard, so keep that in mind. This is basically a table showing very similar approaches with respect to how to respond.
I think it's also good to, mentors I've always had have said, step back, call somebody, talk it out, just kind of get another person's outlook because you're tunnel visioned, right? You're nervous, you're scared.
Yeah, I think that's a great point, actually. I hadn't seen that mentioned, but that makes a lot of sense, especially early on. Dr. Mundis, keep your phone by. So finally, this essentially is a multimodal approach. So multimodal redundancy, that's kind of the theme of all this. Keep in mind, not all changes are irreversible. Occasionally, these injuries do occur. This can lead to inaccurate specificity throughout some of these tests. You'd have more alerts than post-op deficits. So one study showed 6.3% alarms versus 3.4% deficits, which is basically half. That being said, a lot of the ACDF literature I showed did kind of contradict that statement. And then when both SCP and MEP changed, the MEP change led the SCPs by 5 to 16 minutes, up to 33%, or up to 33 minutes. And then adverse events being more closely associated with MEPs than SSCPs, a little more sensitive in the latter to different factors. And losing both, I think most people would think either a technical cause or a surgical cause, so less likely physiologic. But if you lose both immediately, a big change, especially in a smaller focal area, kind of think surgical cause. That's all I got. If anyone has any questions or anything to add, it'd be great.
Great job, Mike. That was yeah. You did a really, really good job. I've heard a lot of neuromonitoring lectures, and that was top tier. Maybe a couple comments. Yeah, I mean, that algorithm is really, really important because it allows you to think through things. If you're working at the same hospital over and over again, I think having that printed out is a good thing, especially if you're doing more high risk cases, because it takes the pressure off you of remembering everything. Because in that heightened state of concern, your brain will sometimes shut down rather than wake up. And so if you have something to lean on, it makes sense, because then you can just start literally one after the other, kind of going through what the potential problems are. The interesting one comment on the MEP thing, my experience is MEP loss is quite immediate. I don't see a lag of that 5 to 16 minutes. I think what they may be doing is, in our room, there's a standing order unless there's a contraindication like a pacemaker or deep brain stimulator, to every 15 minutes run an MEP. So it's possible that something happens on minute 3 and doesn't get picked up till minute 15 because of that. If there is a lag in the sensories, for instance, right? So I wonder if that's where the real lag is, because the reality is, like if you're during, because you hear us right during the 3 columns, it's like motor, like you're doing tons of motors, because you want to know that if the 5-degree change had a negative effect on the neurology. So my sense is that the MEPs are actually are going to pick it up a bit quicker in my experience. Same thing with like the clamping of the thoracic nerve roots. That's key. We use bulldogs, but you can use an aneurysm clip. Bulldogs are free. I don't know if aneurysm clips are or not, but just throw a bulldog on there or something else to clamp it. You can also put a suture on it and just ligate it, but don't cut it. And then you can cut the stitch if you need to. But yeah, I think waiting the 5 minutes is probably ample time, and you're looking for strictly MEP changes, right? Because it's anterior spinal artery, so you're not going to be affecting the dorsal columns at all. So theoretically, within 5 minutes, if you're gonna alter blood flow to that area, you'll start seeing things. And I've had 3 of those in my 15-year career. So that's, in my opinion, 3 saves. Those are cases where we ended up not ligating the nerve root, and we did whatever we could apart from that. So
yeah, I didn't make that connection, the difference of MEPs and SSCPs in that context, but that does make sense. Thank you for bringing that up.
Yeah, good job, Mike. And this is a super important topic for you to become more and more familiar with. It's very popular on the board exam. So it's a good thing that you kind of went into a deep dive, because I know, at least in the neurosurgery, we always get a question or two about monitoring changes in your algorithm. So it's good to have it fresh in your head.
And by the way, you're the expert in the room on this, right? Your neurophysiologist is not. They're recording, they're stimulating. They may or may not know all of this, what we just talked about right there. So when it comes down to it, for sure the anesthesiologist is not. And then there's really no other doc in the room, right? So this is your territory. If this happens, this is like your time to shine, it's so.
Greg, are you still?
Yeah, and definitely get that laminated and put it up on the wall in your OR. So when things happen, you just completely refer to that. Everybody pause and systematically go through it. It's really helpful.
Greg, are you doing video at the same time for records at what you're doing and effect on neuromonitoring?
Video?
Yeah, video of surgical
I wish.
site.
No, we're not. That'd be great.
There were some, records for in the past. I think there was some studies that show while you're doing it, because at the same time you can correlate what happens in this surgical site with changes in neuromonitoring, and that has also helps the person who's doing the neuromonitoring to see.
Oh, you mean when you have I see what you're saying. We don't do it all the time, Dr. A. And what he's referring to is some of the lights have cameras on them. And if you keep the camera on the surgical field, then the neurophysiologist could actually technically be watching the operation and then be correlating live with what they're seeing. That's what you're referring to, right, Doctor? Yeah.
Yes.
Yeah.
Yes.
I think it depends on which room we're in, and then also if we have visitors and things like that, we're obviously a lot more into the videos, etc.
Yeah. Thanks.
Dr. Mundis, is there a set protocol with the anesthesiologist here for your deformity cases? Because it seems like that has a big effect on a lot of this stuff. And thinking back to cases I've seen, I'm just curious if do they all use the same anesthetic approach, or does that vary a little?
They do not. I do wish that we were 100% all on board, but I would tell you the vast majority have a very, very good, of our anesthesia group that works at Green, have a very good understanding of TIVA, and they all will do some version of it. And then they're all, I would say, in general here, you'll see a difference when you go over to Memorial. But at Green, they're all very good about talking to the neurophysiologist before they're getting going. How are the signals? Do you need me to do anything different? I added a little bit of gas. Are you okay with that? They'll look at the MAC. They'll talk it out, you know. So I think the communication piece is more critical than anything. So just keep that in mind. If you're at a new place doing, you know, high risk case, then you have to take the lead as the surgeon and tell them what you want. Because a lot of times when the neurophysiologist tells the anesthesiologist what they want, the anesthesiologist is like, no way. Or they'll like put up a fight, or they'll get a little pissy about it, or just, you know, you're not running anesthesia, it's my case, you know. And then once they knock someone out, then you're like 15, 20-minute delay to get things to reverse. And so I think just clearly communicating before the case is really important.
Okay, yeah, they definitely do.
In general, it's TIVA, right? And yeah, you hear them because you're in their positioning, but they're always talking about that. Hey, how are things, you know? And then they'll troubleshoot together. And then if they're having a problem, then they'll, you know, when I come in the room, that's when they'll say, hey, like, this is what we got. You know, and then we decide, all right, let's switch and go to ketamine. I don't love ketamine because of the post-op effects, but I will tell you, when you start seeing changes and you're not sure if it's anesthetic or not, if you put them on ketamine, it augments the signals. So it's not necessarily a light switch, but you know, if you're having a difficult time getting or maintaining the MEPs, for instance, if you give them ketamine, all of a sudden, like, it gets a lot easier.
Yeah.
Because it augments the MEPs.
Hey, Mike, one other cool thing is UCSF has their complex spine anesthetic protocol published online, and you can look it up. So when you finally land somewhere, it's always great to sit down with the anesthesia team before you start doing cases, saying, here's the protocol I'd like to use. This is the rationale. They can look at whatever protocols or algorithms that they're currently using and make adjustments. And whenever I'm with the new anesthesiologist, one thing that I do before every case is we do a huddle and we go over expectations. We talk about what anesthetic paradigm they're using. We talk with the neuromonitoring. So we kind of go over that. And it's a really good habit to get into. So therefore, you know, nothing's getting dropped and everybody's on board with what your flight plan is.
Makes sense. Yeah, I'll definitely check that out. Thank you.
Awesome. I will say, like,
job,
the vast majority of time, you know why it happened.
Mm-hmm.
It's not.
Yeah. They seem to
so
figure it
subtle.
out pretty quickly, like with especially communicating with anesthesists. Like, did you increase the gas? And they're like, yeah. It's like, okay. I was gonna say that checklist, like I mentioned a couple of times, all that happens at once, but I feel like it's not necessarily 100% happening at once. It's kind of targeted towards the most likely, you know, kind of index of suspicion. You know, what's the most likely etiology? And like you're saying, you know, you have an idea sometimes.
You've seen us we've had signal changes at random times. You're like, that's so unlikely coming from anything that we're doing surgically, right?
Yeah.
So in those scenarios, you're going to focus much more on the other elements, right? And there's other times where you're doing a deformity correction, and you're like, right, like if something fades out here, we know why that's fading out, you know, or you drop something on the cord, you're going to know, all right, well, that random burst of triggered EMG is not random, you know. So
Greg, how about when changes happens when you're closing the skin?
Oh, don't put that on us.
Oh, it's happened to Dr. A and I. Yeah, we open the patient up and take the bone graft out, and the signals come back. Yeah. Or we've had it happen where on kids where we did like growing rods, and we were closing skin, and we ended up having to take the growing rods out because that was the only way the signal stayed there. So then we let the foundations that we had put there, fresh growing rods. We let the foundations heal on their own. the little screws and rods in there. 3 months later, brought her back and put the growing rods in after keeping her in traction for a week. Let her spinal cord kind of relax. So, and then the pediatric world is, I would say, even more complex, as they really like to screw with you.
Yeah.
I think it's a, delay things even after the patient is, 24 hours after surgery. So you have to be careful.
I will say one thing that's really underwhelming is the amount of post-operative like foot drops I've had, or EHL weakness, or some quad weakness when the signals were totally normal. Like those are, I feel like that happens a lot. I don't know if this group feels the same way, but that seems to be the most common occurrence to me. Way more common than having a signal change
if you have like
and a deficit.
Yeah, like if you have a 5-1 ALIF and they previously had like a
Yeah.
in the back or discectomy and there's some scar and some feathering of the nerve, I feel like you got to be really careful with how much you distract the inner space because you never get the signal change. You can always have the issue post-op. I totally agree, Greg, especially with L5 for whatever reason. It seems to be particularly vulnerable and not super offensive.
I agree. I think it's kind of like, and that maybe the pathology is more like a C5 palsy. It's a little bit more delayed. So then maybe they're not picking it up because it's not a problem in the OR, but then 3 hours later, once they're finally awake,
and there's very little
exam
written
on.
about it. Very little written about it.
Yeah. Cool.
Good job, Mike.
Awesome. Clearly an important topic. Thanks, Mike.
Yeah. Thank you, guys.